Okay, well, welcome all who are on this webinar. I'm Amanda Howe, I'm the President of the Royal College of GPs, and I'd like to welcome you to our second in a series of live panel events that the college is hosting for our members. We're wanting to speak to you directly about what's happening during COVID and how the college is working to try and support members at the moment. It's a very difficult time for you and your patients, and you'll hopefully know that we've been putting a lot of stuff on the website. We've been trying to get messages and guidance out through the media. But each week, we're also now doing this live broadcast to have discussions around topics related to COVID, and with, drawing on our leading experts from the college, and you'll have the opportunity to ask questions. You can put those questions to us on the #RCGP Together live tag on through social media, or write them in on the members forum, and staff are on the call to help to pick them up. If we don't manage to address your topic during the session, then please pull it through afterwards, and we'll have a look at those afterwards and try and post stuff through the college's media forum anyway. And you're welcome to contact me, and you can see all the panels on YouTube afterwards. This week, to coincide with Mental Health Awareness Week, we're talking about COVID and its impacts on mental health, your patients, and indeed your own and your colleagues and families. So I've always had a special interest in mental health in the clinical setting and in the academic setting. So I'm really pleased to be able to host this seminar as president, and I'm sure we'll build on the work that we're doing together now for the future. And we're going to talk a little bit about that today as well. The college has been lobbying for good practice in mental health and in mental health services provision for a while. Martin Marshall, the chair, talked a bit about this when he was giving evidence at the Health Select Committee earlier this month. And there are a number of really key issues for us to look at, especially in the context of COVID. It's going to be incredibly important as we move through to the next so-called recovery phase. I'm sure some of you will know that the UN Secretary General actually highlighted the potential global mental health crisis following COVID, because so many people have had losses. At the best, you've lost your normal life, your normal ways of relating and doing things. For many people, they've missed out on relationships, life opportunities. Some people have lost jobs, incomes, and some people have actually lost loved ones to the disease. So, that's a big collective communal trauma. It's certainly not something I've seen quite the like of in my lifetime. But we do have the chance to prevent or minimize where we can, and we do have the chance to try and do the right thing in this aftermath. So that's what we're talking about today. If you haven't already seen it, the college website, CPD, and the COVID Hub have got lots of e-learning modules, lots of stuff about wellbeing. Again, we had fabulous resources already, like the mental health toolkits, but we've got new stuff, additional stuff around the COVID context. Some of those look at how to minimize psychological trauma in ourselves and in others, and how to prevent it being worse than it need be. And we need to go on looking at that, looking at where we are now and where we are with our patients and our colleagues. And that's what the webinar's about. So in that context, I'd like to welcome and thank our panel, Shanti Karupia, Faraj Mughal, Gwyn Elias, Carolyn Graham, and Liz England for joining me. And if kindly, colleagues, thanks so much for giving your time and bringing your expertise to this webinar. And if the first time you speak, you would like to introduce yourselves briefly and say why you're interested in the subject, that would be absolutely fantastic. And we've got some questions we've already had come in, and discussions we've started on, but we're going to add more in the Zoom chat to sort of see, as questions come in, the staff will try and headline them to me, and I'll introduce them to you. So that's how we're going to do it. Now, let's talk first about how things have changed in how we interact with our patients during this crisis, how consultations have changed. Shanti, do you want to start us off, and then perhaps Faraz?
Hi, thank you very much, Amanda. And it's good to join the panel tonight. I'm Shanti Karupaya. I'm a GP practicing in Swansea, Wales. I am South West Wales faculty board member, and I'm also an executive member of Morgano Local Medical Council. I've been working with the Royal College of Wales for a number of years, and we are concentrating a number of things. One of it being is mental health. We are keen to improve the mental health service in Wales and looking at ways in which we can do this, especially to ensure that there is a quick and easy access to the service. Since March this year, I think all of us found ourselves at the forefront of something unprecedented, COVID-19 pandemic. And that had a huge impact. We had to quickly adapt and adopt ways in which that we can continue to provide care for patients, which hasn't been easy. My local health board had rolled out online consultation and workflow model, and a lot of GP practice have adopted that. And we are engaging patients via telephone consultation, video consultations, and also emailing them. The change has been dramatic, but we are ensuring that patients have access to us during this crisis time. And it has been really affecting not just the general population, but the healthcare professionals as well. And we really want to ensure that their well-being is looked after because of this certain everyday changes to our life with social distancing, whereby we are unable to see our family members or friends who form our support in the community. And also the fact that our restriction of our movement as well, and also this lockdown is affecting everyone in different ways, and everybody are reacting to it differently. So it's important that not only general population, but also the carers, the health care professionals, where there are help available, resources available, and we have to encourage them to seek these resources and help.
Mute yourself, Amanda. Yeah, thank you. We'll talk some more about resources and how to do that. You mentioned about most everything moving to online consultation, at least in the first instance, and that's a huge change for us. Do you want to make any more comment about how that's changing general daily practice, please?
Yes, thank you very much, Amanda. My name is Faraz Mughal. I'm a GP in Birmingham with a special interest in young people's mental health. Also a researcher at Keele University looking at self-harm in young people. And also I've been involved with the college centrally and also with my faculty for a long time now. As echoing on Shanti's comments around since COVID-19 really came to the forefront in the UK, examples from our practice, colleagues and I have recognised that virtual consultations seem to be a good way now, back in March, to still try to offer continued care to patients. As a practice, we're a small practice, but we're very much within the culture of seeing patients face to face. And that's what we prefer. That's our way of working. So for us, it was very dramatic, quick adaptation to moving towards telephone consultations and video consultations, which are areas which we're not very experienced in. Bearing that in mind, I know from speaking to colleagues regularly that the practice has taken it on board really well. And patients seem to appreciate still being able to see their GP. Thinking about mental health complaints and presentations, I know that it's a very different experience for a patient having a telephone consultation than in comparison to seeing someone in person in the consultation room, and even over FaceTime or video consultation. So I think it's important to bear in mind when thinking about mental health concerns in general practice, that we still try to provide that face-to-face, if we can, over video, just for that therapeutic collaboration, relationship with the patient, to try to help them in this very difficult time. As Shanti said, the lockdown affecting everyone in many different ways, and mental health is an area that needs to be at the forefront now.
Thank you. And I mean, I particularly noticed one of the problems with some of my mental health patients is that a lot of their face-to-face support mechanisms, things they could go to, places they could see, they've all been shut down as well. So Liz, coming to you, please. So how do you think the current situation's altered how mental health patients present to us? And how do you think we might need to tackle that in the longer term?
Thank you. So I'm Liz England. I'm a GP in Birmingham, and I've been the RCGP mental health lead previously for a number of years, working as a mental health rep now for the college and involved in the faculty. And I do commissioning and sort of mental health service development outside of that within Birmingham. So I'm really interested in hearing both what Faraz and Shanti have said in terms of the consultations being online and Zooming and so forth. I've actually been doing online consultations for a long time, and both video and telephone consultations. And I think whilst some patients definitely do benefit from the face-to-face approach, I think sometimes we're projecting what we want onto the patient, and that's quite important. So actually, whichever mode the patient feels most comfortable consulting us in is the one we should be trying to work with. And I think I probably see or speak to a lot more men during my consultations now that they're mostly digital than I did when we were having face-to-face surgeries. Easy to talk to me, they pick the phone up. Men can't be bothered to make an appointment. I'm generalising obviously here, but and I think it's also, for some men, it gives them a degree of anonymity, which that face-to-face contact can be really quite, it's too much. But I think coming to how it's changed at the moment, I would say that there's three areas or three types of consultations that are really standing out now. So we're accessible by video or phone, which means that I seem to be getting a lot of distress. So not a mental health diagnosis, it's not necessarily anxiety, it's not depression, it's people who are distressed because life is very different. And I think it's really important we don't medicalise that. The second is an increase, obviously, in people who have existing common mental health problems. And it's a very anxious time. Our control is being taken away from us in many situations. So people's anxiety levels are shooting up. There's also quite a lot of change in terms of people's job security, financial security. So I think that's making cases like depression worse because people have then got more to deal with. The other area that I think we're tending to forget about a little bit, perhaps because they don't necessarily consult with us by video or phone, are people with severe and enduring mental illness. A lot of people have had their support structure taken away. They manage by a very, very fine line on many, for the majority of the time, and suddenly whatever little social support they've had or the contact with the community mental health team or whatever, that has changed. And so people deteriorate at home without us necessarily picking them up until they're really poorly. So I think that's one area where we really need to think and be proactive about in terms of trying to support people. But for me, the overwhelming thing has been this distress thing and the fact that I am accessible to people. And it's not a bad thing. It's just that I think it's important that I don't treat it as anxiety or depression per se. It's more adjustment to difficult and changing situations.
Thank you. So lots of themes coming up there. I like the three groups of, lots of people with distress, people whose mental health problems are made worse by, and people who's already in the severe spectrum, perhaps being more at risk than they were. And then the question of over-medicalisation and what's the right social response if lots and lots of people are grouped up in this problem. Now, there are also a couple of other groups, I think, that we've been thinking about for this webinar. One is the group of people with long-term conditions, older people and people who are shielding, I think. And then the other group is people who are, really at risk, suicide, self-harm. How do you pick that up over the telephone? So I'm going to ask Carolyn to comment first about, people with long-term conditions and people who are very much at risk. And then I'm going to come back to Faraj because of the younger population that he's interested in. Carolyn, thanks.
Hi, thank you for inviting me to this panel. I'm Carolyn Graham. I'm a GP in Manchester, still working as a principal. And I'm a Professor of General Practice Research at Keele University, and I work with Faraz. A lot of my work in the past has been around anxiety and depression and distress in older adults. And we've done some work recently on older adults and suicide. And I guess I wanted to raise this as a point tonight, that we forget about older adults and self-harm and suicide. We're all aware that there's a problem and an increasing risk with young people, but there's also an increased risk in older adults. And older adults who've got long-term conditions and who've got a depressive illness and are now isolated and lonely have a much increased risk of suicide. So as GPs, we need to be aware of that. But we also are aware as GPs that actually these people are not consulting because they're shielding, they're isolating. They're actually quite fearful of consulting. They're certainly fearful of coming into contact with the health service, but also they may not have the technological wherewithal to go online and post a question, or to contact the practice by telephone, or they can't get through on the phone, and they can't deal with the video consultations. And again, that's a generalisation. I have looked at shingles rashes in an 85-year-old on using a smartphone, so there's always exceptions. But the group of older adults and people who may be in the younger age group who've got long-term conditions are at increased risk ordinarily of anxiety and depression. And that anxiety and depression increases their risk of poor outcomes from the long-term condition. So it's a cyclical thing. And COVID is just adding to that. So it's almost a triple whammy. So there's going to be, if we're not picking it up now, older adults, people with long-term conditions are going to be presenting, yes, with distress, adjustment at the moment, problems due to loneliness, but in the longer term, we're going to find that people have got low mood, do need support, whether they need psychological therapies or antidepressants, but they certainly need support from primary care. And we need to be aware of the potential for those problems in this age group. And I guess I just want to add one more question about the people with severe and enduring mental health problems. Yes, they're deteriorating quietly with their mental health, but their physical health is also deteriorating. We already know that this group died 20 years before a group without severe mental health problems because of physical health problems, cardiovascular disease, diabetes. The help that they were getting to maintain a healthy lifestyle, perhaps to support to stop smoking, exercise groups, that's all gone. And so people are living at home on a poor diet, perhaps increasing their cigarette consumption, and the disparity, the health inequality is increasing in that group.
Okay, again, we'll probably come back to that, I hope. Sorry. Faraz, before I move to Gwyn, could you just comment for us a little bit about the specific challenges for younger people and mental health at this time? Thanks.
Yes, absolutely. So COVID-19 has really added further potential risk factors for young people's mental health. So we know that a lot of young people have been affected by education challenges, whether they're at university, school, colleges, and young people may also be at home now in environments that make them more vulnerable. And these are some important things to bear in mind. So in practice, I've been speaking on the telephone with increasing numbers of young people who are concerned about their mental health. And as was said earlier, not only new distress, but problems with ongoing mental health problems before the pandemic started. I think there's a few quick things that we can all bear in mind is for those working in primary care are that firstly, now that we're doing virtual consultations more often than not for mental health problems, are that it's important to find out with young people a little bit more about their context of their home environment, to the best of the ability to do so, to bearing in mind safeguarding and if there are any red flags there. Also, depending on the age of the young person, it's important to bear in mind that families and parents can be helpful, but also the opposite as well. They can hinder the consultation. So just perhaps gauge that area with the young person. And finally, I would say that it's a really important time now to just try to think about following up young people who talk to you about their mental health concerns. I know that this is an area that colleagues in general practice find challenging, and we've been trying to do work in the college on young people's mental health over the years. And there are web links, for example, the Mental Health Toolkit on the Royal College of GP website. But it can only take a few moments, but a young person, I'm really sure would appreciate an email follow-up or a telephone call follow-up, or if they're very into their video consultations, just a brief catch-up every couple of weeks even, and then you get to see how things are, and of course general signposting to online resources and any resource in your own area.
Yeah, great, thank you so much. Gwyn, of course, practices are having to reorganise themselves and try and, work differently and look after each other. We'll come back to the GP wellbeing stuff, but would you just like to comment on your experience about how teams can reorganise and help each other?
Thank you, Amanda. My name's Gwyn Elias, and I'm a GP in Leeds, and I'm Honorary Secretary of the Yorkshire Faculty of the College. I'm interested in how GPs can support good mental health and wellbeing through my work with the College as Regional Clinical Lead for Person-Centred Care for the North Eastern Yorkshire, and also in my role as Clinical Lead for Mental Health at the local CCG. I suppose I'd like to tell you about work that I've been involved in with the College in person-centred care, and how it translates into work that I do locally in Leeds as well, in terms of how GPs are supporting people with mental ill health. So just to touch on the person-centred care programme, it's part of the personalised care part of the NHS service model set out in the NHS long-term plan. And I've been working in collaboration with the other RCGP person-centred clinical champion fellow and other RCGP regional clinical leads to link in with NHS England and improvement, to talk about how we can collaborate even further and develop that response to what's available in the community to support our patients. So what came up from that was how social prescribing link workers could be the link almost between the practices and the council, local authority volunteers, and also any local volunteers. So that's really influenced what changes can be made on the grand scale of things. On a local level, I've been working on that in Leeds as well, and championing how the response of practical support to patients identified as being vulnerable has maybe missed out some people with severe and enduring mental illness, or even mental illness related to long-term conditions, who also need additional support during these times. So Leeds has been working on how we can adapt the response so that we can include patients who the practices have identified as being vulnerable, in order for them to access support around things like getting medication and shopping.
Thank you. I mean, I think there's just a group of questions I'd like to pick up there around, we were moving towards social prescribing anyway. And it wasn't clear to me, at least, how many practices were going to embrace that model. But the ones that had been doing it early, it did seem to really help with avoiding over-medicalisation for people with mental health problems and helping them to redevelop life skills. But at a very early stage of development, questions about the skills that we needed to do that, question about equity of access, community capacity, the role of PCNs, lots of things that were running forward anyway. If COVID is giving some sort of additional push to that, there are maybe, some even bigger questions people are asking on the chat line actually about, what will PCNs do? What will they need? Who will be trained to do what? But I can hear the panel, following your example, Gwyn, about saying that kind of community level support and, interaction really matters, as well as keeping in touch with people who don't seek out help at the best of times. Before I switch to the theme of our own mental health and well-being, which is the other big theme we wanted to address, and people are putting up questions already, would anybody else on the panel like to comment on the question about if we've got an even bigger emergence of psychological challenges, what are the key things that we need to develop within the practice and in the other sectors that we really might need to focus on? Carolyn, do you want to pick that up first?
Yeah, so I suppose what I'd like to do is introduce the idea that GPs can teach patients a technique called behavioural activation. It's an evidence-based technique based on operant conditioning principles. The idea is that depression can result from the loss of things, and Amanda's gone through the loss of finance, jobs, contacts, a loss of our future, and that can cause depression. And one of the ways of targeting that depression is to adopt different behaviours and look for functionally equivalent behaviours. So thinking with patients what they used to like to do, and if they can't do that now, what can they replace that activity with? And this is a technique that I would use when I was seeing people face to face. I would give them diaries to fill in, and you can get diaries online. You can also do this through virtual consulting. So you can do it by telephone, you can do it by video. And as Faraz says, it's really important to follow people up with mental health problems, not just make them feel they've had one consultation and they're abandoned. And behavioural activation is a technique that you can use in repeated consultations, reviewing people, how they're getting on, what didn't work, what did work, what can facilitate something working next time. And whilst it's it's a technique that's used in psychological services and therapies, it can be taught and can be done by GPs in our 10-minute consultations. And so I would really make a plea for people to have a look. There's lots of information about behavioural activation. I did a blog for the Richmond Group of Charities, which is an initiative looking at how we can improve the care for people with long-term conditions, including mental health problems. And behavioural activation is outlined in that blog. And I'll tweet that again tonight. And that just briefly outlines the technique that we can use in our consultations.
So one of the big obvious is that if we're on top of our game and we're motivated as individuals and our practices are motivated and we spend time building up, relationships and collaborations with the third sector and our mental health service colleagues, we've got a lot we can offer. If we're burned out, if we're afraid, if we're, struggling with what's going on now for ourselves, our practices, or we go into defensive mode, and I've seen this again happen, not just during COVID, but sometimes people just don't take on the mental health side of work because they can't handle it. So let's switch now, colleagues, to our own well-being and what we can do in now and later to support ourselves and our practices and, you know, and our patients, because if we can do it for ourselves, we can do it for our patients too. I'm going to do Gwyn, because you've run some wellbeing seminars, and then come to Liz, because you've been putting up quite a lot of stuff about
Hello. So yes, as part of my work with the RCGP Yorkshire faculty, we've been collaborating with other faculties in the North, in the White Rose faculty, to run some webinars to support our peers. I've been involved in running the mental health webinars, of which we've already carried out one which was very well received, and included a guided meditation session, and we're planning on running another one maybe next week, so keep an eye out on the college website. But yes, Amanda, back to that theme of how this is Mental Health Awareness Week this week, with a theme of kindness. GPs have been working very hard now since the lockdown, and in a very intensive way and a very different way, and we've had to do a lot of learning of new skills and adopting new practices and ways of working. And I think as GPs we're so used to putting ourselves last, but it's really important for us to also be kind to ourselves, and also look out for our colleagues. So I really like the RCGP Wellbeing framework that's being developed at the moment, in response to the COVID-19 pandemic, just because it categorises what we can do to take action. And there are things that we can do for ourselves, there are things that we can do as a team, and there are things that other people can do for us externally. So the webinars have been what we can do externally, but in addition to that, I've been part of setting up a peer support programme for mid-career GPs in Yorkshire and Humber, as a collaborative partnership with the CCG, the Clinical Commissioning Group, the Yorkshire and Humber Leadership Academy, and also the Leeds Local Medical Committee, to be inclusive of all GPs really. It's also supported by the Yorkshire faculty and members of the White Rose faculty, but it's an evolving process, but our focus is on the future and what skills and career development that GPs will need in the new world. So I think it's almost timely to sort of talk about this in relation to COVID, because now that we're working virtually, we could probably have a virtual group such as this and open up the next event in June to anybody who'd like to join, to support more GPs.
Thank you. Liz, you've got some thoughts on peer-to-peer support and looking after ourselves. Do you want to headline some of that, please?
Yeah, thanks. So the RCGP had a wellbeing webinar on Monday evening that I took part in, and that will be available online. But I think some of the takeaway points were really important. So we talked about having peer-to-peer support, perhaps reactivating Balint groups that I know some of us will remember. If those aren't available, then proactively creating something, having something where you can share your levels of stress really, and that kind of idea of reducing risk amongst yourself. But the other things that we looked at, and then that can lead on to suggesting things for patients as well. So there's lots of things like Mind has a group that is monitored and policed, that's not the right word, but I can't think of the word, where people can contribute. So things like that for patients. I think the other thing is, for those of us who are feeling well, and perhaps for college leadership in particular, I think it's really important that we model the behaviours that we want to see in other people. So actually, it's okay to say, I'm not okay. We need to be able to say that. We need to be able to be honest with each other. And I still think there is stigma around it within the profession, saying that, you know, people have been stressed, suffered with anxiety and depression. 1 in 4 of us will have had some sort of episode. So out of the people on this call now, you know, you can work out for yourself that. And I myself had problems, and I talked about it, and over time things get better. So it's good to share that. But I think if we want other people to talk about it, other colleagues and those people that we're supporting, then we have to do it too. The other things that we talked about were making sure that we know, I think what Carolyn was saying, if you've got some skills that you can use in a consultation, you're not just helping your patient, you're helping yourself. So rather than sitting there being frustrated, overwhelmed, not knowing what to do, where to go, you don't need to have a psychology degree or, you know, complex skills. You just need to be able to do some problem solving, perhaps some behavioural activation, basic coaching, and that actually makes you feel a lot more empowered and in control of things. And I think patients value that too. So I would say tool up is the expression, and, you know, just read around it and just get a few ideas. What would you want your GP to say to you?
Yeah, great. Thanks, Liz. And we've got some resources on the website again, I think, already, which prompt us, remind us what we need and what we could be checking with colleagues and friends. Shanti, I don't know if you'd like to comment on this theme about looking after ourselves and our teams at all. And then I'm going to come to a set of questions after that that's come in about a particular group of patients' needs that I'll pick up in a moment.
Well, RCGP Wales and Royal Pharmaceutical Society launched MDT resource, multidisciplinary team resource, because the way the GP practice is evolving, I think we are trying to ensure that the patients are accessing the right professional help at the right time. And this also enables delegation of workload. So at the moment that most practices are delegating their work, working with other allied health professional, pharmacists dealing with drug queries, physiotherapists, occupational therapists, we have practice-based paramedics and in-house counselors. At the moment at my practice, our in-house counselor is offering her service to all the clinical and non-clinical staff during this crisis. So which has been brilliant, because while working, sometimes you get stressed out, and we want to ensure that people connect while working, and that they're aware there is someone that they can turn to and contact if they feel that they need to talk about the way they're feeling. Self-awareness is very important, and I think all healthcare professionals need to be aware about their feelings, what they're feeling, and discuss about with their colleagues, which we are not doing enough.
The other thing that I was thinking about was that it's actually quite difficult for people who aren't in a regular team. So we've had some people returning to practice but doing remote triage. We've got locums who are actually being underused at the moment because everybody's battened down and not had holidays and so on. And I sort of worry a little bit about people who are feeling isolated in practice. Now, I would say, colleagues, if that's you on the line, please think about emailing somebody in your local faculty, you know, another GP, you know, I'm sure that rule of saying, you know, please reach out if you want some support, and people hopefully will be kind and responsive, and certainly the college would want to be there for you. But has anybody got any particular initiatives that allow people to be included across their community, even if they're not linked to a particular practice? I see Gwyn was saying that there's a Leeds toolkit for staff. I don't know if you want to tell us.
Yeah, so using the RCGP framework for stress and wellbeing as a foundation for this, what I did was try and organise the offers that were already existing into the different categories of self, team, and external, so that you can choose which level you want to go in at, or which ones or if you want to do all of them. But yes, coaching and mentoring feature highly, and a lot of people have spoken to me about that in my peer group, in terms of goal setting and finding direction, but also being kind to yourself and allowing yourself that time. But yes, picking up on Shanti's point about how self-awareness is really important. I think that sometimes we're very good at talking to our patients about signs of stress, but I think we need to also be mindful of the physical signs, or the sort of difficulty concentrating and sleep disturbance, things like simple things that we can be looking out for ourselves, and just sort of pointing that out to ourselves is sometimes a nice reminder to sort of think about ourselves again with that theme of kindness. Yeah, so
that's
sorry,
great.
I'll let someone
Thank
else
you.
talk now.
Cool. Now, there's a group of questions that have come in about what people are calling post-traumatic stress reactions. And two groups. One is the patients who've had COVID and have survived, or have not, but their families, and, come off ITU, come back in, and is asking, what resources exist to support those people, and what can be doing for them in the first period. But also, is there anybody else who can help us with that group at this stage? And then similarly for practitioners, if people are burned out, feeling stressed, feeling very fearful, what resources should we be drawing on for them and for ourselves? I'll chip in two things. For the practitioner side, we've, again, in the last week, the college has put 2 new resources on the CPD hub, specifically around PTSD, prevention and recognition and early management. And, definitely colleagues already here are saying to you, colleagues out there, get your head around that literature, because it gives you really good insights, early warnings, early interventions. There is research in that, and we can usefully draw on it. The practitioner health program, Claire Gerarda's, group, we've had some webinars with Claire already. They're offering confidential consultation, sort of doctor's mess kind of model. So we've got a service that can help us individually. But still, if people have, could we pick up the question about what resources are there if you do recognise somebody's got PTSD from their bereavement or their experience in hospital, or from the work that they've had to do? What other resources can we draw on? Again, I don't want GP to do everything. We need to know what else is out there to help.
So I think for patients, I think it's really important that GPs are aware that this is a potential problem. I think we perhaps haven't been aware previously that post-ICU PTSD is quite common. 20% of people will get it. So with more people being discharged post-COVID, we're going to have a big influx of people with distress and possibly with PTSD. So the first thing is to be aware of it, ask about it, because people think it's an odd thing. They don't recognise it as PTSD. So we need to ask the questions. ICUs often offer support for people. They're increasingly recognising that this is a problem. And so actually contacting the ICU that the person was on to say, what sort of clinics, what sort of follow-up do you have if there's nothing in place? But I think we will have to think that our IAC service is going to have to pick this up. And I'm hoping in Manchester that there are going to be discussions about commissioning a service around post-COVID-19 recovery, which will include PTSD.
Liz.
Sorry. Yeah, so thank you. I think there may not be specialist services that are available locally, but certainly PTSD is very amenable to treatment. So I think firstly being aware of it, asking about it, making sure we're identifying it, and then, we can't necessarily treat that ourselves. Linking in people to IAPT services, for example. Some people are going to need the next step, which might even be to be referred to their community mental health team. I think with this group of patients, I think the most important thing, though, is us actually being aware and picking it up, because I think it's a group that are unlikely to seek help necessarily or be aware of what they've got. They're older people, they may not recognise what PTSD is. And so they may just think that this is what happens. So I think, everything we can do to support them on that journey, keeping things together, arranging referrals and things, it's good, and we'll take them that step further towards recovery. But I think one of the things that I think, from my commissioning background, I know that commissioners are thinking that because of the levels of distress, there needs to be lots of low-level resources being put into place. So that's your basic things, things like, for example, the RCGP works with Public Health England on the Every Mind Matters programme, which is, it's looking at low-level interventions for things like good sleep hygiene, healthy eating, exercising, developing healthy behaviours and routines, the stuff that works before you get to the mental illness type. And that's what we need to be pushing regularly, making sure everybody is aware of those resources. I think I'd just like to also mention that for colleagues and for doctors, there are lots of resources that are seen to be coming online now. And I think we need to be making sure amongst ourselves, and the college is doing this, it's putting it on all the relevant web pages, that we are promoting things. So in my area, NHS England is offering 1 or 2 coaching sessions, for example. So if you're sort of at that point where you feel, I really need a break, maybe from general practice, or I can't take this much more. Actually, I've had coaching before and it was brilliant. It really invigorated me and gave me that space to start to think, this is what I want to do, and it's just a temporary blip. So I would recommend that for everybody, and have a look and see what's available.
Thank you. So the other group of questions that I just want to pick up before we come to the end of the session is around what else we need to do structurally, let me call it, to make the whole service picture work. So we've talked about self-care resources and things people can do on. We've flagged up, social prescribing, community link workers. But people are saying, so how much will the PCNs engage with this? What models of care do we need? We need to extend perhaps our skills in the practice. Somebody talked about having their own in-practice counsellor, maybe those are models we need to be talking about, but also making sure that these services are fit for purpose. And I know that around parts of the country, we were struggling with that before COVID. And whilst I will, be very confident the college will go on advocating around the right mental health services, of course, we've got a devolved picture. We've got 4 countries and we've got different regions, and some of them are innovators, but some of them may not be so far ahead in terms of commissioning or collaboration. So what do we need to be doing or standing by to make sure that the whole picture of the sector works in the next phase, and that it's equitable? Because for every innovative area, there's one that's really on its knees, and you know what I mean. And so I think that's a really big challenge. And if anybody's got any wisdom for our community in the last few minutes of this webinar, bring it on. Unmute yourselves and come in, colleagues. Liz, thank
you. I want to say to people, be militant, but militant is a bit too strong a word. I think be very proactive. So a lot of us don't get involved with things like how PCNs are developing, or we don't particularly get involved in what's being commissioned locally. Now, having worked as a commissioner, if somebody, a colleague, a GP, came to me and said that there was something that needed doing and we needed to think about that, then I would I'd think about that seriously, because we're on the ground delivering care as such. So I think as an organisation we need to be pushing mental health resources, fit for purpose, available, accessible, but also within our own groups keep pushing the agenda as well, not only for patients, but for resources for us as well. So making sure things like practitioner health programmes are funded, equivalent of occupational health services and so on. And I think you just have to keep being vocal about it. I find that easy to do.
Can I add that?
And then Gwyn.
In addition to that, I would say that the NHS long-term plan pre-COVID did commit to community and primary care, mental health and self-harm models. And it's really important that the NHS moving forward, post-COVID, whenever that may be, that these commitments are still honoured. And the college, certainly I'm sure that they will advocate and push for that seriously. Secondly, the point around devolved nations, we have lots of different contexts. Manchester's very, very different to Birmingham, and Wales is so different to southern England. So it's important that CCGs and PCNs work in teams in their regional locality to really get a feel for what the local population needs, but also in terms of services, not only to commission services, but alongside that, there needs to be piloting and evaluation of services to ensure that we know that the service is being rigorously evaluated, so that it doesn't just continue to be a poor service, for example, but improvements and amendments and adaptations can be made to offer the best care for patients in that area.
Fabulous, thank you. Gwyn.
So what I'm hearing is a lot of talk about future planning and what can we do now to build the future. And I think general practice has been given an opportunity with the PCNs and primary care networks to look at what practices need and what our local populations need, because often I think sustainable GP workload depends on what is coming in from the general public and the care needs of our local populations. So by understanding our local populations, which many of us already know a lot about because of all the work that we do in terms of the long-term conditions, I think that we're best placed to be thinking, well, actually we are different to a different PCN and we need this sort of focus and this sort of staffing and planning ahead for workforce. So I think we've been given a real opportunity to do this, and we should go for it.
Great, thank you. Any other colleagues want to add anything before I summarise? And Carolyn?
Just two very brief things. One is that we've had to change considerably the way that we consult with our patients and interact amongst the practice. We need to take some of those good things with us. We need to learn, I think, what we're doing in our practice, and I think what most practitioners are doing is looking at what's worked for which group of people and taking those with us. We don't want to go back to where we were before. And I think the other thing is about developing a positive practice culture. So the research I did with a research team around GP distress pre-COVID was demonstrated the importance of how the practice culture and supportive or unsupportive colleagues could impact on GPs' mental health. And I think practices pull together, and many practices will have developed that practice culture. I'm sure some haven't. But I think, again, it's learning lessons. What has helped us to work together so well during this crisis? What can we take forwards?
Thank you. Well, that's a beautiful note to end on. And I certainly have noticed in this period that the efforts from colleagues to look after each other and it has broken down hierarchies. We've had different conversations, and remote working in some ways can be permissive. You know, I actually think patients sometimes are a bit more confiding because they're in their own home and they're a bit more relaxed than when they've had to run down to the practice. So let's definitely hang on to that sense of empowered relationships. Let's still remember that mental health has been stigmatized even in our, you know, modern culture, and that it's much more correlated with health inequities. So patients who are deprived and in difficulties and vulnerable tend to have a much higher rate of mental health problems. And so there's stuff about making innovations and recovery equitable and supporting the practices in areas that really, you know, have the biggest challenges there. I think the college, again, is working very closely with the BMA around issues about development, effective developments of PCNs, but I've really captured that from what's been said tonight, or the equivalents in the other countries, and keeping the social capital being built up, you know, realizing we're all in it together. You know, I can't do my job unless you do your job, unless we've got some informal care. You know, respect to all the informal carers in the care sector who've taken a lot of the brunt of this as well. If colleagues are still looking for further information, not only will we be posting this, you know, on, and I gather there's been a few glitches on the YouTube channel, so I'm sorry about that, but hopefully the recording will stand and will be okay. And again, if people want to add to the debate or questions, we've got social media, we've got the members forum. Please use the resources on the hub, and please take part in the future general practice discussions where we can build this theme in and talk about, you know, what works and what we're going to need more of. I'm really grateful to the panel who've joined us and given their time. I've found that really, you know, inspiring myself. Very grateful to the staff who've helped us to convene this. And hopefully it'll be a good resource to build on as we go into the next phase. So please, colleagues who are listening, you know, keep looking at RCGP together. Post your stories, you know, add your photo, tell us what's worked for you, and keep safe and go well. Thank you.